Good afternoon. Good afternoon, everyone. If we could have the room quiet and get everyone situated for our next session, that would be fantastic. I know it's been a long day, but we are eager to get started on this very important next topic. Thank you so much. We appreciate your attention. Our next session, our next policy and advocacy session, is creating insurance and payment options that support improved outcomes in diverse beneficiary populations. We have two fantastic speakers, and I am going to introduce each one. They'll have about 12 to 15 minutes to present, and then we will go into our question and answer session. So without further ado, Matt Eyles is Executive Vice President of Policy and Regulatory Affairs at America's Health Insurance Plans, the national trade association representing the health insurance industry. At AHIP, he leads the government programs, state policy, and product policy departments, and a team focused on broad health policy. Matt joined AHIP from Avalere Health, where he was Executive Vice President for Consulting, Strategic Communications, and Healthcare Reform. Previously, he served as Corporate Vice President of Public Affairs and Policy at Coventry Healthcare, which is now an Aetna company. He was also Vice President of Corporate Public Policy at Wyeth, now Pfizer, and led policy for pharmaceutical, consumer health, animal health divisions in the U.S. and globally. In addition, Matt has worked at Eli Lilly and Company and began his career at the Congressional Budget Office. Matt has undergraduate degrees from the George Washington University in Political Science and History and a graduate degree in Public Policy from the University of Rochester in New York. Please join me in welcoming Matt Eyles.
Thank you for that nice introduction. Good afternoon, everyone. I'm really pleased to be here. As Courtney mentioned, we're actually former colleagues, work together. It's always nice to have a reunion with old colleagues when you move around a lot. And so what I wanted to talk about in the next 10 or 12 minutes at a high level are really some of the ways that health plans are already trying to focus on diverse populations and serve the needs real broadly across different groups. And so just to set a little context about the role that health plans play today in terms of serving populations, really we're serving diverse populations across multiple programs that you are probably all familiar with. They're very important programs to ensure that people have access to coverage, including the new exchange marketplaces where more than 8 in 10 people receive low-income subsidies. The Medicaid and CHIP programs in Medicaid managed care plans today serve more than 50 million people in the United States, and increasingly are serving beneficiaries with complex medical conditions where states are expanding the program. In the Medicare Advantage program, of course, a diverse group of enrollees, many with lower incomes, a higher proportion of African American and Hispanic Americans are enrolling as well in these all-in-one health plans because of the value they provide. And also in Medicare, Medicaid plans that serve dual eligibles. Increasingly, states are looking to managed care plans to serve these populations. Some of the strategies that plans are employing today already to ensure healthcare equity are really important. I just wanted to touch on a couple of them because they're critical to helping eliminate healthcare disparities. The first component or strategy is community outreach. And working with community-based organizations to make sure that beneficiaries are aware of plan programs, and particularly health plans are increasingly contracting with these organizations to ensure that they're part of their provider networks. Some of the other elements are just as important, and I'll highlight a couple, such as the use of technology and texting to ensure compliance with appointments, to make sure that beneficiaries have understanding of the different resources that are available to them. Health plans are conducting more and more cultural competency training with their staff to understand the populations that they serve. And plans are also collecting data on racial and ethnic makeup of their enrollees to make sure that they're putting in place the programs that represent the populations that they serve. And these programs are working, and I'll just highlight a couple of the successes that we've seen in different areas. And one, starting on the left, in particularly a study in Minnesota done by the Department of Health Services there, looked at the cervical cancer screening rate for African Americans in Medicaid managed care plans versus the fee-for-service program, and they found higher rates in Medicaid health plans. A study in Health Affairs looked at enrollees with diabetes in Medicare Advantage, so-called special needs plans, and found that people are getting more primary care visits, and this is leading to lower admission rates. And then there's additional studies that have happened that look across the diabetes population, that look at how to serve Medicaid enrollees more effectively, again, by leveraging technology. In particular, one novel program, for example, texts pregnant mothers who have diabetes to make sure that they're monitoring their blood sugars and have better glycemic control, and there's evidence that these programs are having success. One important element around health plans that's important to measure, or that is important to note, is around quality measurement. This is really a critical area that health plans focus on, because plans are being measured across all of the activities that they're doing, particularly as the governments become a bigger payer. Plans are really being held accountable for their quality metrics and making sure that they are leading to better outcomes, more access to care, and hopefully, at the end of the day, better health outcomes and lower costs. And you can see just some of the examples of the different programs here. AHIP in particular has been very focused on quality and trying to recognize the challenges of multiple metrics across different programs, and recognizing that physicians, and for those physicians in the audience here that are getting bombarded by various quality organizations and plans and others around metrics, AHIP has worked collaboratively with CMS, some physician societies focused on primary care, and specialty groups to develop core measures in the 7 areas that you see on the right here, starting with ACOs and patient-centered medical homes down through obstetrics and gynecology. And really the goal is to get better alignment across the commercial marketplace and across Medicare to reduce the administrative burden that physicians face so that they can spend more time providing care and less time on administrative items. And I think we're looking forward to figuring out how to expand this to an additional group of measures. More specifically around lower income populations and those plans that are focused on low income populations, health plans recognize that there are some unique challenges faced in accessing care. For example, it might be in difficulty affording transportation to go to their healthcare providers. Health literacy might be a challenge, linguistic or other cultural barriers. Research has shown that low-income populations are more likely to suffer from multiple chronic conditions and others. And one interesting and important element that plans have found is that there's growing body of evidence that low-income and other diverse populations are harder to reach when it comes to making sure that plans are able to meet the quality metrics and trying to put in place novel strategies to make sure that we're doing the appropriate outreach to make sure that people are getting the care they need and that we're able to measure quality going forward. And I'll give a couple of examples. One particular example that we see is in the Medicare Advantage program, where we see different levels of performance around some important quality metrics. And this chart on the right is just meant to show that those Medicare Advantage plans that have at least 50% of their enrollees that qualify for the low-income subsidy and might need extra assistance are not scoring as well when you look at their quality metrics. And the question is, what's going on here? Are these plans just performing not as well, or is there something else going on? And what has been discovered through a lot of the research that's happened is that there are some systematic differences in how quality metrics are playing out. Despite efforts to do outreach to lower income populations, whether it be through door-to-door outreach or tailoring culturally sensitive programs, or trying to focus on particular chronic diseases. And at first, the work that health plans had done with CMS was really not well received. CMS's original perspective was that there really shouldn't be differences across populations, and perhaps it was just due to poor plan performance. But a growing body of evidence has been developed, again, over the past several years, and most recently, CMS actually commissioned some research with the RAND Corporation to look at the impact of lower socioeconomic status on quality ratings, and found that in 7 out of the 40 measures that there were statistically significant differences. And there should be some more research that comes out from HHS later this year that should help inform how we can develop more effective targeted programs to make sure that people are getting the care that they need and that we're having the best outcomes possible. In fact, CMS has taken some initial steps right now, looking at the next plan year to make some sort of adjustments to account for low income or disability status. But I think the perspective from plans is that this is an important first start, but it probably doesn't go far enough yet. And there needs to be some more meaningful adjustments as we learn more about this population and how it's being impacted by different quality metrics and different programs. As an industry, the health plan community has developed a number of proposals to improve quality measurement because we think quality is so important. And the takeaway really just from this slide is that it's important to get greater alignment across different programs. We need to make things simpler and easier to make sure that what happens in Medicare that is appropriate for the exchange marketplace or to Medicaid managed care takes place. Sorry, I should have jumped ahead. We also need to make sure that, that the adjustments that occur to pay for quality make appropriate accommodation to look at vulnerable and disadvantaged populations. And we think that there's a lot more work by CMS that needs to be done in this area, and health plans are working and talking with CMS about this on a very regular basis. Finally, let me just close by saying that the health plan community is very focused on diverse populations, given the members that we serve. We believe that innovative and forward-thinking programs are really critical in this regard. And that might take the form of innovative quality and care coordination programs where people recognize the importance of making sure that there's continuity in care and that there aren't drop-offs when people go, for example, from the hospital to step down and lower levels of care. Much better efforts to integrate mental and physical and behavioral health. I think that's a growing area where people really recognize that you can't just focus on a part of the person. You need to focus really on the entire person and getting better integration across physical and behavioral health. Effectively using technology to work with enrollees to get better health outcomes. Again, technology and smartphones are so prevalent, and being able to leverage that technology to help drive better patient engagement is really an important step to making sure that we're able to realize the promise of all that healthcare should be. And finally, and this is the capstone that holds it all together, is really access. How do we make sure that patients get the right care from the right provider at the right time? And plans are very focused, whether it be in the construction of their plan networks or how they ensure providing caseworkers and other health coaches to make sure that people get to the right provider at the right time. So thanks for the opportunity to share some of those perspectives, and I'll look forward to some questions after the next speaker.
Thank you, Matt. Thank you. So our next speaker is Allyson Schwartz. She's actually a former member of the U.S. House of Representatives from Pennsylvania who served from 2005 to 2015. She is a nationally recognized leader on healthcare issues, having worked as a healthcare services executive Allyson Schwartz was elected to the Pennsylvania State Senate in 1990, serving 14 years until her election to Congress. In the state Senate, she was the driving force behind Pennsylvania's CHIP program, which was a model for the federal CHIP program 5 years later. In Congress, she was appointed to the powerful Ways and Means Committee in her second term and served as a senior member of the Budget Committee. In both capacities, she was a strong advocate for Medicare. She was instrumental in passing the landmark health reform legislation, authorizing key provisions such as the ban on pre-existing conditions, exclusions for children, and increased access to primary care. She is a distinguished policy fellow at the University of Pennsylvania's Leonard Davis Institute for Health Economics, visiting fellow at Wharton, Public Policy Initiative, senior fellow for health policy at the Center for American Progress, and co-chair of the Bipartisan Policy Center Health and Housing Task Force. Please join me in welcoming Allyson Schwartz.
All right, well, thank you and good afternoon. I feel like I should be, as a member of Congress, you're supposed, I could get used to saying things like, anyone from Pennsylvania here?
Pennsylvania.
Oh, right, okay, well, that makes me feel better. Okay, good. Thank you so much. It's good to be with you and to be able to talk about the new work that I'm doing, which really builds on the work I've been doing for many years, which is to assure access and quality and affordability of health care for all Americans, including for seniors and for the disabled who rely on Medicare. And really, what I want to talk about this afternoon is, of course, a focus specifically on what's going on in Medicare Advantage, particularly for diverse populations and racial and ethnic minorities, but to talk about some of the innovations and what's happening and enabled by the financing under Medicare Advantage. So I look forward to the opportunity to talk with you about that. And if I have time, I'll talk a little bit about the organization Better Medicare Alliance that is really just over a year old. So I'm really pleased to be with you today. And it starts with really just an understanding of really what's changing in the number of in the population of seniors in this country. And we have, many of you will know this, we have many more seniors every day in this country. We have 10,000 people turning 65 every day in this country, and that'll continue for at least the next decade, and over the next 25 years we're going to see almost a doubling in the number of seniors, people over 65 in this country. That's an enormous challenge for all of us, not just for Medicare, but in many, many ways. And in that process, who are those seniors is changing as well. And ethnic minority populations are increasingly high percentage of who those seniors are in our nation. Just in 2003, it was a little over 17% of older adults were racial or ethnic minorities. 2013, went up to about a little over 21%. And by 2030, it'll be almost 30% of everyone who's over 65 in our nation. There'll be 75, 78 million of us are going to be ethnic and racial minorities. It's a pretty big growth, obviously, in the change of the numbers of seniors and who we are. So we have to get ready for who we are and what we're doing. And some of that, I believe, is really what we're doing. Oh, and I apologize for how little this chart looks if you're looking at it. But maybe you can see some of that information. And you should know that everything's on our website, so you can go and take a look at what we're doing. But Medicare Advantage, which has been around for a long time, but particularly in the last 10 years, has seen a very strong growth in the number of seniors who have chosen this option within Medicare. About a third. It's actually a little over a third. It's really 33% of all Medicare-eligible Americans have chosen Medicare Advantage. It's 18 million people. So it's a very significant part of Medicare today. We used to think of it as a little program over there. No, not so much. It's really very much a choice that seniors are making. And why are they doing that? What we hear from seniors is that they find the affordability, the simplicity of the billing, because it combines Part A and Part B and includes enhanced benefits and often has Part D added as well, is really very helpful. And they very much appreciate the care coordination. There are some keen differences between fee-for-service and Medicare Advantage, and one of them is the coverage. Medicare Advantage is required to cover all the benefits under traditional Medicare. In addition, they are able to use any savings that they get, some of it comes from the star bonuses on quality, to be able to reinvest those dollars in additional benefits, called them enhanced benefits. 97% of Medicare Advantage plans offer at least one of the options of dental, vision, hearing, some kind of fitness program. Over 50% of Medicare Advantage plans provide all three, vision, dental, and hearing. Now, it's not everything you want in those benefits, but it is something. It's an eye exam, it's an annual dental exam, it's a hearing exam that is not covered under traditional Medicare. And in addition, they use some of these additional dollars to be able to reinvest in things like care coordination, which I'll talk about a bit more. Second is that there is a cap, unlike in fee-for-service Medicare, there is a cap on annual out-of-pocket spending. And for seniors who by and large live on fixed income, they have figured out exactly how to make ends meet, and every additional cost is a big deal. And knowing what to expect is a big deal. So knowing there's a cap annually, and right now it's $6,700 a year. Well, that sounds like a lot. You know that that is all that you will have to pay, should you have to pay that amount if you get really sick. And one other thing I'll just substitute for the last one is, which we'll talk about a little bit later, but it was mentioned already, Matt, is quality measures. You know, quality measures are not done in this holistic way in fee-for-service. In Medicare Advantage, there is a requirement of quality reporting on different quality matrix, which will change over time, by the way, I think, to get more complex and more interesting. But you can, there's a rating system for every Medicare Advantage plan. It's 1 to 5 stars, and 71% of Medicare Advantage plans are over 4-star rating. That's pretty amazing. It shows you what incentives do. You know, financial incentives do. They drive behavior, and if they say you provide higher quality, you can get some additional payments and use those payments for those enhanced benefits. Well, it's working. These plans are paying attention, and those quality measures are not for a particular population; it's for everyone. You've heard it. We'll talk more about that, as you know. So, just quickly by the numbers, I'll try and run through some of this a little bit quickly so we can get to questions, but there's a lot of important information about what is changing under Medicare Advantage. Does it make a difference in the quality of care? So we're trying to measure that. It's not all known, but we wanted to start with who was in Medicare Advantage. So I'll come to these numbers. Matt used them so I can do them quickly. 37% of Medicare beneficiaries live on less than $20,000 a year. $20,000 a year. It's not a lot to live on. That's what 37% of Medicare Advantage seniors are, or disabled, are living on. 44% of Hispanic seniors have chosen Medicare Advantage, and we have 31%. Matt had 33%, so we'll find out who's more accurate, but we'll take it. I'll take 33%. I know it's growing, and it's close to that. So I'll say it's about a third of African American seniors have chosen Medicare Advantage. And again, this is an annual choice that seniors and those who are eligible make. I'll also say that 26% of individuals who are duly eligible for Medicare and Medicaid, you know, those are even poorer seniors, have chosen Medicare Advantage, and 50% of individuals who are duly eligible for Medicare and Medicaid then represent racial and ethnic minorities. So that's a pretty significant number as well. On health outcomes, we do have some data on that. The way Medicare Advantage gets paid, which is a capitated amount per person per month, enables the ability of these plans to offer better quality care, we'll talk about some of that, but also better management of chronic conditions. It is one of the advantages is that if you know what the money is going to be, you don't wait. It's not a fee-for-service where you wait for the person to come to you. You start to think about what is the smartest way to get people to slow their disease progression, what kind of disease management programs can we implement, second point we're making here, and particularly for seniors who have multiple chronic conditions. If I was to ask you if any of you are seniors, if I ask in a group and I say, do any of you have one chronic disease that requires a medication? well, they all laugh because, of course, they all do have something that you're taking some medication for, and you probably all do as well. If we asked to raise your hands, how many have 2 chronic conditions that they have to pay attention to? How many have 3? How many have 4? It is increasingly a fact that we see seniors and certainly some of the disabled who are really dealing with 3 or 4 serious chronic conditions. Managing those conditions, taking the right medication, knowing which doctor to see, having access to a primary care physician or primary care practitioner who can help you organize your care and is really very significant. It is a confusing, often, and difficult health system to navigate. And if you're 85 and elderly and not feeling well and not have a lot of money, it's even worse. So you know what up against. Quickly in primary care, one fact I'll just give you, there's more here, but you're 20% more likely to have had a preventive care visit with a primary care practitioner, 20% higher, which is great. Those care managers matter. There's a lot more patient engagement. And there is also a real effort to identify and intervene with illnesses early. So I'll just, that coordinated care, extremely important. We have some of the members, some of our ally organizations who talk very actively about having a healthcare coach or having a case manager who can call you and say, I know you just received this diagnosis. Do you understand your medication? You haven't filled your prescription. They can know that as well. Can we help you with that? Can we get somebody to deliver it? Can we find out whether in fact you have other kinds of needs that need to be taken care of? And again, on chronic disease, just a couple of statistics, and all of these are from independent organizations, academic institutions that have done these studies. They're not company data, they're not one specific situation. So 26% of people who are duly eligible for Medicare and Medicaid and are enrolled in, you heard about it in MA, but data shows a 19% reduction in hospital inpatient days and a 28% reduction in hospital admissions for those who are chronically ill with diabetes. The average length of stay for individuals under 65 with a disability is 12% shorter for those on Medicare Advantage. Being able to get care in an outpatient setting, being able to slow that disease progression, preventing those hospitalizations, again, for anyone, but particularly for seniors, particularly the older you get, that can be very disorienting to go into the hospital, to have to make that transition, to be away from the things you're familiar with, to be able then to go into rehab, to go home again. It's sometimes very, very challenging and can lead to even greater problems. Told you about the enhanced benefits, so I can run through that. But let me just say that there is really keen attention to closing the gap in health care and health status. Not only getting the health care that people want, need, they're required by law, but to actually begin to say, how can we help people be healthier? How can we slow that disease progression? And we're seeing some sonic success and really outcomes measured, and we're interested at Better Medicare Alliance in doing this research and seeing this research is done. But we have one study that showed a 62% reduction in serious heart attacks. That's pretty good. That's one study, but we'll see what they're doing more, and a 42% decline in stroke mortality. These are very significant numbers. And a study that we just came out with, that the American Academy of Family Physicians Robert Graham Center showed in 12 states with a high penetration of Medicare Advantage beneficiaries, a 10% reduction overall in avoidable hospitalizations. That can be duplicated all across the country. That's quite significant. So just really end by saying that I believe very fervently that Medicare is a promise that we have made as Americans to each other and to our seniors. And in order to fulfill that promise for all those millions of new seniors we're going to see in the next 20 years, we need to really take seriously what more we can be doing to get more value out of our dollars. How can we move from volume to value? How can we make sure that there's greater patient engagement? You heard about telemedicine, that's one way, those innovations. But how can we reach out to people where they are with what they need? We're seeing a great impact with primary care and care coordination. And of course, affordability makes a very big difference if you can afford to go to see a health practitioner, and there's one in your community, and there's one who will see you. That all matters a great deal. The use of technology, telemedicine, really interesting things going on there, and innovation in trying out different models of care that work. And one of those models of care is community partnerships. And this is increasingly, as an old social worker, I have to tell you, it seems incredibly obvious to me, but the fact is that if you can find out what it is, so the social, environmental, family issues that are going on for someone who may be 85 alone on a third-story walk-up, who really can't get out the door very easily by themselves, doesn't have a health center near them, doesn't have healthy food near them, doesn't have public transportation near them. All these things have a dramatic effect on health outcome. And increasingly, even in Medicare Advantage, they're starting to recognize that this matters. So there are some partnerships with the YMCAs for fitness programs. There are partnerships with area agencies on aging to have home visitors. There's an awareness of maybe the need to again, send a health coach or make a phone call or a text, or to create a way to have more interaction and to really find out, are there family supports? If they're not, what else can we do to make sure that that person is as healthy as they can be? Mm-hmm. So on behalf of Better Medicare Alliance, which has 50 ally organizations, one of them is the National Minority Quality Forum, and not only is the forum of ally, but it was one of the first. It was a founding ally organization, as was the Hispanic Medical Association, as was just a couple of other minority represented organizations. We just had the National Black Nurses join us because they recognize the importance for their patients, but also for them as nurses to be able to provide the care that they want. We continue to grow, and I thank Gary Puckrine, who is a huge advocate for Medicare Advantage, particularly with his keen interest in diabetes for the African American community. If we can slow that disease progression, if we can reduce the incidence of people who end up on late-stage renal disease, it's a huge outcome for that person, for their family, and actually for all of us. So we are working to meet that promise of Medicare and to meet that promise of quality health care for all seniors in this country. Thank you very much.
Great, so we're going to take questions over here. Absolutely. So I just wanted to make sure that the audience was aware of the mics in the room, but I wanted to go ahead and take the liberty of addressing the first question to our panelists, so that we had robust dialogue, because earlier in the day there was a lot of sidebar conversation about the role of the plans and how the different community groups could partner, particularly from a policy perspective. So I was just going to open it up and for both of you to address how can the disease groups, the patient groups, the community members partner both from a policy level, and what tools and resources do you all have, or your member networks, to empower and engage their respective organizations to be able to help impact change, advance the cause of diversity? Matt, do you want to?
Great, sure. Thank you. It's a really important issue, right? That the ways to get things done in this town certainly are by working with allied organizations and trying to identify those areas of commonality. And I'd say at AHIP, you might know that we have a new CEO and president, Marilyn Taverner, who used to be the CMS administrator. And I'd say one of Marilyn's really key goals and priorities is changing the way that perhaps AHIP has operated from the previous, in the past, and made some changes to make sure that we are doing outreach to various stakeholders and making sure that we're engaging. And I would encourage all of you to reach out to us if there are particular areas that are affecting you, whether it be in Medicare or Medicaid or just insurance programs more generally, access. We want to hear what you're working on. We want to understand your perspective and try and find those ways that we can work together. AHIP has a terrific depth of staff expertise across different parts of healthcare. If there are questions, data, or other resources that you're looking for, or connections to health plans. Since we represent the largest number of health plans in DC, please outreach to us. We'd be happy to try and find the way to work together with you directly or find connections with the plans that operate in the communities that you're serving.
I'll say, well, Better Medicare Alliance is a stakeholders organization. That is who we are. So we are made up of a variety of stakeholders groups, and so that we include some of the insurance plans, but we also do have we have some national associations. I mentioned the Hispanic Medical Association. We also, I should say, have the National Medical Association is also an ally organization. We do have some of those AAAs. We do have the American Osteopathic Association, the American Nurses Association, the Nurse Practitioners. We have some other aging advocacy organizations. And that's who we are. It's sort of not a sideline for us, it's who we are. And we like to look to all of our allies, both for their perspective, and their engagement, and their how they see the policy impacting them, and believe that the reason that they have become ally organizations is because they see Medicare Advantage as the potential of enabling them to do what they believe they need to do for their own profession, but also for their beneficiaries. And it is. It's interesting. We've actually reach out. If any, recently a few months ago, we made a decision to not just look at inside Washington at the national associations, but also to include some regional and state organizations as well. So some of our ally organizations are very much local organizations working with provider groups and interested in doing more. I have to say, some of this is evolving. Those area agencies on aging, they never thought about being a subcontractor to a dual eligible plan run through the states. They didn't even think about that. They just thought they would do their thing and healthcare would do their thing, and they would probably complain about each other a little bit, and sometimes work together. But so it is a bit of a new world. We're very interested in hearing from any of you who might run one of those organizations or be a part of one of those organizations to see whether you would be interested in being an ally organization. And if you're a nonprofit, it doesn't even cost you anything. So it's we would really be interested very much in being able to bring that perspective to the Hill and to policymakers to understand the impact and the consequences of some of their decisions.
Thank you. We have a question here from the audience.
General internist, about a third of my patients are Medicare. I would venture to say half or more are in Medicare Advantage plans. Because whether they have an income of $20,000 or less, they're sensitive to the savings, that they have with being in a Medicare Advantage plan. But as a provider, some concerns are, one, some of them have, there's some challenges with doing referrals. For my patients, I have to send to a specialist. Some more than others. And then is there a location where all of the plans listed for Illinois or for Chicago are listed so that we could give that to patients when it's time for open enrollment, so I can tell them these are the plans I'm in, because every year we tell patients, don't select something until you talk to me so I can tell you if I'm in my plan, in that plan. And they don't, and they end up, being somewhere else because some person on the phone has said I'm in a network that I'm not in. And when will they start getting punished for giving out that kind of erroneous information?
Yeah, I'd actually be pleased to address that question. I mean, the plans that we work with are very focused on the accuracy of their provider directories. And this is one of the most important tools that either a prospective Medicare Advantage member or anyone who's signing up for any program really can look at to understand what plan to choose, and then also how to use your particular benefits so that you're going to in-network providers and not hit with surprise bills. Right now, AHIP is in the process of operating some pilots in different states, unfortunately not in Illinois, but one in Indiana, to try and find the best way to make sure that that information is updated in the most timely, accurate manner, because there's a challenge sometimes, at least in terms of when, for example, say a provider has said, we don't want to accept any new patients with this particular type of plan, or we've changed our office hours, or we've moved. and trying to make sure that that information is accurate. And so at least in the exchange marketplace, which I know is not Medicare Advantage, on the healthcare.gov website, that there's requirements around providing provider directories, and there's requirements that Medicare Advantage plans have, at least in terms of doing updates to their provider directories and making sure that they do outreach to their providers at least once every 90 days to confirm their information. So it's out there. I will say it's a work in progress and more needs to be done, but I know that plans are intensely focused on trying to make sure that that's an element that is accurate and up to date.
I've never gotten anything from someone asking me to update my information that I can recall. And if you've got a need to do a pilot project in Indiana, that says there's a need to do something across the board. Okay. Every year, someone says, they told me you were on the plane, you were on the whatever. Yeah, they would, and every year, no. There's some plans I've never been a part of and won't.
Yeah.
I think Matt did a good job of answering this, because I think there's work to be done to make sure it's being done well everywhere. It's a very dynamic situation, and so really just making sure that information is accurate and understandable. And it's pretty confusing when you get that open enrollment period and there's so many choices to be made and so many decisions to be made.
That's right.
Obviously, the decision about particularly your primary care practitioner is extremely important, as one that is very high on the list. But I think it's work that's being done to make sure that there are standards, and there's accountability for those standards. And when they're not met, there are consequences. So it is really, it is something that I think that there's.
I didn't hear that, and I didn't hear an answer to. Is there a location I can go to find out what's in Illinois or in Chicago?
Medicare.gov.
I don't know that there's a single repository that exists that has that information. Ultimately, that's where the pilot projects that AHIP is running, we hope to get to essentially what would be a central repository of this kind of information that could be leveraged nationally, no matter where you live. But to be honest, we're just not there yet. And it is a two-way street in that the plans need to do the appropriate outreach to providers, and we need to get the information back. And hopefully what we'll learn from this pilot is what's the most effective way to get that information that's at the lowest burden for providers, so that they can just do it in one place, and then it would be shared broadly with all of the health plans. So there shouldn't be any reason why, if you move and you needed to tell the Blue Cross Blue Shield of Illinois that Aetna couldn't benefit from your providing that information once, but those systems are still being built.
Okay, thank you.
Thank you for your question.
Hi, I'm Cynthia Hernandez-Cancio. I'm the Health Equity Director for Families USA. It's a national consumer healthcare advocacy organization. And before I ask the questions, I think there are a couple of things I can do to help you out. And one is that right before open enrollment starts for Medicare, you can just go on Medicare.gov and put in a zip code and see all the plans, because I've done this for my mother-in-law. I know that's possible. So that's one way to see how accurate that is, another question, but at least that's where you can find it all in one place. And the other thing is that the accuracy of provider directors is a policy issue that Families USA works directly on. So if you want to look up familiesusa.org, there are some people that are doing really good work there in my office on that issue. The questions that I had is, there seems to be an inherent tension between doing the work that needs to be done to adjust for SES and other factors when it comes to quality measures that are payment related, in order to make sure that you don't undermine the providers that are already doing what they can do for underserved communities. Versus, though, if you just hold them harmless, then where are the incentives to make sure that, even though we understand they have very complicated, hard to treat patients, that there is still a reason and a way, an incentive to specifically work on addressing and improving the outcomes and the care of communities of color. One question that some people have brought up sometimes is having a quality measure be specifically the one that gets paid for, right, that you get incentivized, reducing a health equity gap, right, reducing a disparity of some sort. So I guess that is, that's a question that I have. Like, It's very complex. We understand, and we know that the National Quality Forum is working on some pilots on that and so forth. But I'd be very interested in hearing about your impressions on how to tackle that. And then the second quick question, since there's nobody else, I guess I can ask it, is in we just came out of a workshop or a panel that was about designing benefits. And one thing that Families has worked on a lot is the use of standardized benefits. That would help, that would include some before deductible coverage for chronic diseases or things that could be very, very helpful for communities of color that have a higher burden of that. So for example, it's great that you can get a free screening under the ACA for diabetes, but then you have a $6,000 deductible, you can't afford to do anything about it. And a standardized health plan that would include some of that would be a good way to address this. I'm very interested in your opinions on those kinds of plans. Thank you.
You guys
Do you want
got
me to
that?
start?
Okay,
Yeah,
absolutely.
I'll start, and then I can weigh in on this as well. Both great questions, by the way, and you hit on some that are really right at the forefront of what we will be looking at over this next year. We being a very broad community who cares about getting quality health care to everyone. You're absolutely right. The issue around the whole issue of dual eligible enrollees, Medicare, Medicaid, poor populations, and in many cases minorities, but not only, obviously, and the concerns about whether, in fact, you're, how do you maintain, I'll say it positively, how do you maintain the highest quality? And you don't reduce the quality measures or give them longer time or excuse lower quality because, in fact, it's a poorer population or a sicker population. And how do you do that while you recognize that it might be harder to get those folks to where they need to be, and for a variety of reasons. Maybe some of that will change once we have healthcare really access for everyone. Before they're 65, it won't be as much of an issue when they're 65, but it really is a challenge. And all this because you asked the question, but this year, because of the changes CMS just made in creating a change over how they're going to look at define dual eligibles into 6 subcategories now, and it's an interim. We're going to look at that for a while and take a look at that and look at star ratings separately and see how that works. There's really going to be quite a bit of attention as to what will work best to ensure that the plans, and I think the particular concern is plans that see very high numbers of low-income people who have very big challenges. And I think this is a change. It's complicated because it's Medicare and it's also Medicaid, which is really very much run, as you know, is run by the states. So states are different and locations are different. And my guess is the challenges are in some cases different as well. So I'd be happy to talk with you. I think we'd be interested in talking with you about some of your thoughts. But we were very concerned about these changes and the impact it would have on the quality and making sure that the expectations about quality are high for everyone. The second point I'll make about the universal benefits, there's a lot of interesting discussion now about, there's VBIDs, about value-based benefit design, and that is a very interesting one. And again, there's sort of, I suppose, some pitfalls in this. You want to make sure that you're targeting some of these, to do it in a way that is not discriminatory, that is actually targeting the very those who need it most, again, who are probably the sickest. But this is very interesting, and for those who may not know exactly what I'm saying, it's just there's actually a demonstration project under CMMI. We'll find out soon about who's applied for that, encouraging some of the plans for particular populations or particular people even to be able to lift some of the obstacles that people have. So I'll give an easy example. Somebody is diagnosed as pre-diabetic. How do you make sure they get to see that specialist without any copays? You see them regularly. You might actually give them some additional attention to make sure that they're eating and exercising and doing the things they might. The way Medicare is right now, you have to give everything to everyone equally, when in fact there are people who are at higher risk for some conditions than others. That's true for cardiac disease, it's true for lung disease, it's true for so many. And how can we test out lifting these restrictions or making sure that people have access and that the benefit design is actually very tailored to the individual person. It's very interesting to me to see how that plays out. That CMMI study, I think it's supposed to take 5 years. That seems like a long time to wait to get an answer on that. My guess is that we'll get some better expectation. But even now, there's a lot of interest on the part of the plans to try and figure out, does it make sense for us, and this is happening for under 65 as well, but does it make sense because we are capitated? You probably heard some of these stories. These are more anecdotal than universal. Does it make sense for us to pay for that transportation? Because that person cannot get to see the clinician, then wait till they show up in the ER 6 months later, much sicker. Or what, a story about it, this was a child, not a senior, a plan buying a vacuum cleaner, and his visits to the ER for his asthma, was cut in half, just by that, And so these are things that seem, they're challenges though, because what about the next person who wants a vacuum cleaner but doesn't have asthma? I don't know. It's sort of interesting just to figure out how do we do this in a way that actually does tackle the real problems and help people be healthier and help them get the health care that they need.
And I think Allyson did a wonderful job just explaining the challenges, especially in the Medicare Advantage side. And I think we're optimistic that CMS is going to recognize that additional resources should be provided to those plans that are serving higher levels of low-income populations, because they need to be able to channel what the resources again to where they're going to do the most good. And we think that what they've done so far is a good first step, but we're looking forward to working with the agency as they refine and learn what works and what doesn't. More broadly, to your other question on standardized benefits, and certainly there's been a lot of discussion about ways that we can evolve the system to provide better coverage upfront for different conditions. I'm sure that this group's aware, at least the ACA has the free preventive care visits. Obviously, there's some complexity in that and what counts for being preventive versus being treatment. But I think looking at things like benefit design and how do we ensure better access to preventive care is certainly a good start. We have had some concerns about CMS trying to put in standard benefit design requirements, because it might actually limit the ability of plans to do some of these novel programs by trying to tailor co-payments, right? Because again, if you're going to make them different in one area, that could be viewed as discriminatory, or you have to do it in all areas. And we want to make sure that we're incentivizing high-value care and doing it in a way that makes sense, rather than just saying that the government sets a standard for how it should occur.
Thank you for your question. So in wrapping up, I just wanted to kind of tie it back in. Matt, you mentioned healthcare literacy. Allyson mentioned care coordination. If there's one pearl of wisdom from everything that was shared today, if we could just give that to the audience for their takeaway in terms of reaching their constituents, that would be great.
I think making sure that the plans that operate where you live and work and the populations that you serve, making sure that they're aware of the resources that you can bring to bear. I think there's a lot of great efforts by plans, but they don't know everything, and I think they'll be the first to admit that, and they can learn a lot from you, at least in terms of how to do the best, most targeted, effective outreach to the communities that you serve.
Well, I do too. No, as an alliance, I have to say one of the things that we're very interested in is sort of, our models that work in the community. So we would engage as many, again, of the different people who are working and different organizations that are working in trying to create these partnerships that really make a difference and have insights that and models of care that we can highlight, that we can articulate, that can be shared, so that very best practices can become the norm of what we do. Understanding that there are different models in different places and different geography requires different things, and that flexibility provided through a capitated system that Medicare Advantage allows, it really is very exciting. The second thing I was going to say, which I didn't mention, is we do reach out to beneficiaries. And we are an organization that looks to engage both the providers, the payers, and beneficiaries in speaking up for what works under Medicare Advantage and how it works best. So if you know some people, and some of you, that isn't just beneficiaries, it's also providers, can all go online to bettermedicarealliance.org and tell us your story. You can become an individual ally. You can become an advocate for for Medicare Advantage, and tell us your stories, and tell us and in ways that we can then amplify that here in Washington to make sure that we're getting this right. It's a transformative time in a lot of ways.
Absolutely.
In healthcare, particularly in Medicare. As you know, there's never enough dollars in Washington, so there are challenges to say we do something great, but how do we actually do that, get that done, and how do we scale it up?
Exactly.
So these are not easy questions to answer, but I think there's a lot of wisdom in the communities all across this country, and we'd love to actually hear more from you. And you can talk to me afterwards. You can talk to Audra Adolfo, who is my communications director, and happy to share with you our cards and our information, and look forward to working with you.
Before we thank the panel, how many of us in the room are patients or take care of a patient? Okay, so join me in thanking the plans for being here today. Thank you.